Good afternoon, everyone. Welcome to the August meeting of the Public Health Advisory Board. July. Wait a minute, I'm not ready. Why do I have August? Okay. Welcome to the July meeting of our August board. Thank you. That's what I was thinking. Excuse me.
I'm sure you were.
So let's go around and do introductions first. Unfortunately, we're a smaller group than usual today, but this is Jeff Luck, Oregon State University Chair.
Terry Tollifer, I'm Director of North Central Public Health District, and I represent the smallest counties.
Tricia Tillman, Multnomah County Public Health Director. I represent the urban counties.
Katrina Hedberg, State Health Officer.
I'm Carrie Bergiotti, Union County Center for Human Development, and I represent CLO.
And so, do we have any board members joining us by phone today?
Hi, this is Muriel Dielenbrand. I'm Kirk County Public Health, and I represent Small County.
Great. And Muriel, please, if you have any trouble hearing us, let us know.
I will do that.
Okay.
Sorry I couldn't be there in person. It's just, I was out of the office all last week, so it's been crazy.
No, we understand. Thank you for joining us.
Thank you.
And are there any?
Alejandro Queral, United Way. Sorry I can't be there in person.
Again, thanks for joining us telephonically. Are there any other board members on the phone? Okay, thanks. So let's see. So Sarah, how many do we need to have a quorum if we have two on the phone and 1, 2, 3, 4? Just
you have 14 voting members, I believe, so you need to have at least 7, and it looks like you've got 5 voting members.
6.
6.
2 on the phone and 4 in the room.
6.
Okay, so we're one.
Yeah.
We're one short of a quorum. So I think that means our first item on the agenda of approving the June minutes will have to wait. But there's a possibility we may have another member joining us later. And if so, we'll try and take that up again. If not, pick it up at our next meeting. So we have actually a bunch of important stuff on the agenda today. The first one that we've been looking forward to for a while is to hear about the AIM High update, the meetings that were held at 10 different locations around the state to talk about public health modernization. So we'll be hearing from Kathleen Johnson about that. The 2 sections of the state health improvement plan we'll hear presentations about today: oral health and suicide prevention. And then the second half of the meeting, we'll be talking about the guiding principles for public health and healthcare collaboration. A couple board members will be talking about feedback they've gotten. And then at the end, we actually get to talk about having some money to spend on modernization. Not nearly as much as we hoped, but certainly more than nothing. So that's actually really good news after several months of just not knowing. So that's our plan for today. So thanks. So I've got just a couple updates to make before we delve into the agenda. 2 upcoming membership changes on the board. One is that Diane Hoover recently left her position as public health administrator in Josephine County, and therefore we're recruiting another member to represent the group of counties that she represented. So it was great having Diane here but unfortunately for not that long. So the other news about membership is a great addition. House Bill 2310 added a slot for a tribal representative, and so that person is being recruited, and hopefully that will be able to happen fairly soon. and we'll keep you all updated. Let's see, so we've got, oh, for those of you all here on the phone, Lillian is not here today. She's on vacation, and Kara will be joining us for the latter part of the agenda. So we've got just a couple updates. The first, I think I'll ask Dr. Hedberg to talk about the State Health Assessment Steering Committee. A couple of our board members are on that, and you've begun to have meetings. So would you just tell us the latest there, please?
Yes, thank you. We did have the first meeting of the State Health Assessment Steering Committee, and I think it went very well. I can't remember how many folks participated overall, Sarah? Yeah, most folks, yeah, 12 or so. Unfortunately, there was some folks attended by phone, and there was a little bit of technical difficulty, so that is one of the things that we're trying to iron out. But the people in the room were very engaged with the whole process, and were really excited to look at what's happening with the assessment. I think we presented before about the different elements of the assessment. The main thing that sort of the next action step is there are going to be 2 subcommittees. One of the subcommittees is the health status assessment, which is really looking at the indicators that you're all familiar with, reviewing what we currently have and what other potential quantitative data we might look at. And then there's also a subcommittee looking at more of the qualitative, the strengths, community strengths, those kinds of things, including, and one of their mandates is to look at or to give some advice around the community listening sessions, which will happen over the course of the fall. Those community listening sessions haven't quite been finalized, but we really are committed to having those around the state. And so we would encourage FAB members to attend some of those community listening sessions when these are coming to your community. So we will have, again, there's proposals to have a couple in Eastern Oregon, at least potentially Pendleton. I don't know, Terry, if Pendleton's closer to where you are than Portland, but
It depends on the traffic.
yes, but as well as down in the valley, Bend, the coast, etc. So again, they haven't been finalized yet, but like I say, people were very engaged and a lot of feedback, and other than, and I won't say the minor technical difficulties, it actually was relatively problematic to not be able to have folks participate more robustly over the phone. So we're working to address to make sure that not all of these meetings will necessarily happen in Portland. So I would ask, Sarah, do you have anything you want to add to the state health assessment overview of the first meeting number 1?
Yeah, one of the other pieces we're doing is an assessment of the public health system. Whoops, sorry. And so basically we'll be doing a webinar. We're not convening a subcommittee for this body of work, but we'll be doing a webinar going over everything that we learned from our public health modernization assessment and everything we now understand about our public health system, and then trying to draw the connections of how it and in what ways it's relevant for the state health assessment. So that'll be done over a webinar on July 31st, and I think we'll be sharing that information. For those of you that want to participate, you'll probably be very familiar with a lot of the information, but of course we'd love to hear your thinking about how it's relevant as we think about the health of the population in Oregon.
Great. And will you guys be able to record that?
Good question. We can try to do that.
Because I can think of people outside FAB who might want to hear that, even if they're not able to be present at the same time.
Great, thanks.
And Katrina, I'm sorry, when did you say the listening sessions are going to be held roughly?
So roughly in October.
Okay.
So again, there's a little work that the committees need to do beforehand. So they will mostly, I think, are going to be held in October thread. It may take a little bit longer than that, but we want to be sure to first get those on the calendar. But again, a lot of the work about what's going to be discussed at those listening sessions hasn't been fleshed out until the subcommittee. So we're sort of thinking about when they are, getting them on the calendar. At the same time, we're trying to make sure that, that we tee up the work that we need to discuss at those community sessions. But anyway, and those, of course, really are community listening sessions, and so we would encourage not only folks that are on the steering committee, but we had reached out if they had suggestions of partners who needed to come, and again, the FAB, and we are serious about wanting to hear from communities about what a state health assessment means, what it should entail.
Great, we'll look forward to that. Thanks. And so our other update is from Dana Drum from Public Health Division. And so Dana, you're going to tell us about some transitions in public health agencies.
So Kara and I agreed it makes sense to kind of provide an update to this body. It's been a very busy summer in terms of some of our local health departments and changes that are happening and happening pretty quickly. So the first is Wallowa County had previously been served by 2 staff people. The administrator resigned and has moved on, and so they are have the other staff person that's been there has now been appointed the public health administrator. But what that has meant is for them to look at how some of the services are delivered. So some of the direct clinical services that in particular require a licensed medical professional, though they are partnering with a clinical partner in their community to provide those services. They're still working through that. I think the last I heard, those services are still going to be provided at the health department, but I'm not positive about that. And then WIC is also no longer going to be provided by the health department. It will be provided by the Umatilla-Morrow Head Start, which provides Head Start in Wallowa County and has already been providing WIC services in Umatilla and Morrow counties. And then it's not totally clear yet where tobacco prevention is going to ultimately sit. The health department has said they are not able to do it with one staff person, and they have not been successful in finding a community partner within the local community to take it on. So I think we're looking at we are working with them around some other possibilities. And I will just let you know, I mean, this happened in a matter of about 2.5, 3 weeks. So it's, I think we talk a lot about sort of planning regional partnerships, and the reality is that I think staffing and budget situations at the local level are driving things to move pretty quickly. The second county of interest that we're working with is Lake County. They seem to be moving forward to contract for almost all of their public health services with the hospital district there. And we have heard that there's a public meeting scheduled in that community on August 1st to talk about this transition. But my understanding is that it will be happening most likely very soon. And then finally, you mentioned Diane Hoover. She has moved on to become the program manager for the Blue Zones project in Southern Oregon. And with that change, the county is looking at how public health services might be delivered differently there. Currently, they do have an interim public health administrator in place, but they are actively working with their local partners around, in particular the clinical services, but I think they are also looking at how some of the other services might be delivered differently as well. So I do know that, I think there was an article in the local paper saying that public health was going to be going on in whole to all care CCO, and that's actually not the case, but they are, I think, actively looking to see what public health services are going to look like in that community moving forward. So, one of the things I would just say, my observation is that by the time county commissioners are looking at how public health services should be delivered, they seem to have a fairly good idea in their mind about what that will look like, and they tend to think about other non-governmental partners, which is different from how we've talked about in terms of cross-jurisdictional sharing with other governmental entities and across county lines. And I think we are in conversations with the Association of Oregon Counties and the Conference of Local Health Officials to figure out how do we start to shift thinking so that there could be a variety of models considered when a county elected officials are feeling like they need to do something differently, because one of the complications is that there are certain things that a local public health authority has to do, that there are governmental functions, and so making sure that those specific governmental functions are still being met. There's continuity of services in the community, and there's just a whole lot of pieces that have to be held together there.
Okay, thanks. It's, any questions or comment? Okay, well, yeah, please keep us up to date on what happens in those 3 counties.
Well, and there are likely to be more.
What's driving, when you say more, what's driving the,
I
mean, what forces make you think that?
I know that
there
I get calls saying we're being asked to look at other options, and a lot of it seems to be driven, at the moment, it seems to be driven by budget crises. That's a huge piece, or if there's a dramatic change in staffing. And but often it's not a new thought. It's something that folks have been thinking about, and those kind of moments create kind of the crisis by which some sort of action is taken. But I don't expect. I mean, I think we are naive to think that these are the only 3 that we're going to be seeing this conversation with in the next while.
So actually, if you wouldn't mind, just, we won't be meeting as FAB in August, but I don't know if there's anything else. If there is, how do I say it? If there are transitions at other counties, if you could talk to Kara about a way to inform the board by email, I think we'd appreciate that.
Absolutely, we can do that. I don't know of anything imminent, like between now and September, but I just know that this is it seems to be on a lot of county commissioners' minds, and questions are getting asked, and it seems to be that when we are at the end of a budget year, start of a new budget year, and that creates times when staffing and budgets change, and that can become the impetus for it.
And it's also a time when we're going to be talking about RFPs for modernization, expecting things from local health departments. So, yeah, thanks for just giving us any additional news. Okay, so that's our update items. So, Kathleen, would you?
Do you have
So-
a preference for where I sit?
Wherever you wish.
I'll just pick the closest one to me.
Just make sure your
Yeah.
red light is glowing when you talk.
Just getting situated. Just getting situated. So thank you for having me. Before I start, I think most people at this table, maybe with the exception of 2, this is my last day with Chloe. I am, yes. I am not gone from public health, though. I'm actually moving to Washington County. I will be the senior program coordinator for environmental health. So I'll be working on non-regulatory environmental health work, which I'm very excited about. And so I am staying in the family. This is not the last time you'll see my face, certainly, but just not in this capacity. So
But it's been great to keep you updated. I've been really honored to work on modernization and be a part of this Robert Wood Johnson Foundation grant. We are certainly leading the way nationally, and I think I'm thinking really creatively, at least how we support our local health departments in moving this forward. And so it's really been a great learning experience for me, and I've been excited to be a part of it. So I was at the May meeting, a few months ago, talking about the kind of preliminary results from the 10 statewide Aligning Innovative Models for Health Improvement in Oregon AIM High meetings that we had that took place late fall to early winter. And so I'm here to provide a more formal kind of closing update on data that we have analyzed from those meetings, or I should say the READ group has analyzed from those meetings, talk about next steps. And the other thing I'll talk about that happened in between when I spoke with you last and today is we, as a part of our Robert Wood Johnson Foundation grant through the Public Health National Center for Innovation, they did communications polling work in all 3 states that are participating in the grant. And so I'll talk a little bit about the data that we received from there that we're doing some communications work around. And I also think it's just really timely, and particularly for the stuff that, the items that Dana mentioned just now. So for the report, we do have a statewide summary report, and I've included pieces of that report in the PowerPoint, but I think you might also have the report in your packet, and I'm looking at Sarah for that. No?
We did not include it. We can send up a link
Okay,
to it.
that would be great.
Yes.
And it's also available on our website, but we'll have Sarah send that too. So next slide, please. So as you know, we had, I'm sorry that's not, the color on this is strange, but it's not showing up very clearly. But we had 10 meetings, and the map that you see before you and in your packet is where those meetings took place. We covered all corners of the state, and that's just there for a reminder. Next slide. But I think at the last meeting I talked about the total number of people that attended, and this is just more a further breakdown of who attended by sector, and so you'll see the numbers there. But I think in total we had 454 people attend these meetings, which I think is a pretty good turnout. And we had, as you can see in this table here, quite a good representation of different sectors and partners attend those meetings too. And so I think the reach as far as talking about what public health modernization was pretty far. Next slide, please. And then the next table is just the breakout of the people, the number of attendees at each meeting there, the date in which those took place. And so, our smallest meeting was in Pendleton, and I think that partly was driven by just, it was one of the rescheduled meetings, and so just in conflict with other things that were scheduled. It was just a smaller group than originally anticipated. But we, for the most part, depending on who, again, as a reminder, it was up to the local health department of who they wanted to invite as far as partners went, and who attended. And so you'll see some variation just depending on who they strategized as essential to attend. Next slide. So this is getting a little bit more into the visualization of this data summary, and I think I shared some of this last time, but what we looked at with the data were in kind of 3 primary buckets, one of them being challenges to implementing modernization, and far and away change management was the biggest challenge to implementing a modernization. The thing that we heard most consistently multiple times at each meeting is, I'm going to need support as a local health department in transitioning my staff, my community, figuring out clinical services, communicating that, and really just kind of breaking down, if we're modernization, we really want to walk the walk, really figuring out also how to break down silos and really integrate systems. And so you'll see that broken out there because it was a major theme. The other thing to note, and it's as an asterisk at the bottom of the slide in the report, just by nature of way that the meeting were facilitated, people were only allowed to say funding as a barrier or challenge to implementing, and so that is probably a bigger challenge than it is represented here, just because we told people they couldn't say funding. So that's just something to note. And then again, you see here local policy, local politics and culture. So depending on where you are in the state, depending on the type of work you want to do, that might be a challenge for some local health departments. Workforce capacity, I think that's probably connected to funding as well, but just both capacity in training and workforce development, but also just people in seats and FTE, I think is also a challenge to implementing. The role of public health misunderstood, and I think that that's probably a very true theme for what Dana had just brought up as well, and that being a challenge to implementing public health modernization. And you'll see actually in the polling data when we get there, and in some of the fun data that we have in the back, that's probably not a surprise and indicative of some of the data that we have from other work. Geography is a small theme there, and that certainly came up in our frontier counties in the east side of the state and some in the southern part of our state as well. Communication expertise and technology, so just again, I think that that's probably connected in some ways to the role of public health. So those were the major categories for challenges, and if you go to the next slide, these were the opportunities that came up for cross-jurisdictional sharing. Assessment and epidemiology came up most often for people, and I think that's because it's one of the things, one of the greatest needs that we have as a public health system is access to that local relevant data. And I think something easy for people to wrap their minds around for how they could share that, because it's something that most of our health departments don't have. And so it's kind of a value added thing. And then leadership and organizational capacities, that a lot of that 13% there was around training. So sharing training opportunities for staff and leadership. Communications, people saw that as an opportunity, and that was kind of in the context of shared media markets, kind of communication support, so kind of tools, resources that people can use and adapt to their local needs, but just having that available or a way to regionalize that, or sorry, I shouldn't probably use that word. Opportunities to share that or do different business models for health prevention and health promotion. And I think that some of that was around the new work within prevention and health promotion and modernization, emergency preparedness that came up, and a lot of there's sharing, at least just by nature of how the preparedness program is already set up in our state. And so I think that was an easy one for people to get behind because the program is already designed that way. Communicable disease control, policy and planning, resource availability, environmental health, and access to clinical preventative services. So you can kind of see that pretty much covers most of modernization, but you can kind of see it kind of go down to the bottom. But the top four are probably, I think, the ones that people saw most easily shared, at least at the start. And speaking of sharing, on the next slide, this slide and the following one are maps that with READ we've been creating to showcase the type of sharing by foundational public health program, and then the other one is foundational capabilities that are already happening in our state. One of a lot of the data that we collected is what are the existing sharing relationships that are already occurring. And our funders at Robert Wood Johnson Foundation are very, very excited about this work and these maps, and just kind of as a way to visualize the sharing that's already happening. And selfishly, as the coalition, we saw this as a great opportunity to have a tool to share with our elected officials to say, to help them understand that our public health system does think innovatively. We do different service delivery models, and that this is already happening. And so you'll see on the right-hand side is an overview of the number of sharing arrangements as it relates to the foundational programs, the number of counties engaged, and then it's then broken out by the foundational programmatic area. So environmental health, health promotion, communicable disease, and access to clinical preventative services. And then it's probably hard to see it here, but in the state right, but you have full slides, so it's not hard for you. But that little legend there shows the type of sharing that's happening, and then the lines connect between which counties. The check boxes are just to show more for our internal purposes, to show counties that we have verified these sharing arrangements with. And so we're still in the process of verifying a few of them, but we've got most of the state covered. The next one is the foundational capabilities. And so again, it's the same map. If you go to the next slide. It's the same map, but just with the capabilities, and so you can see the sharing arrangements that already exist there. I do mention it at the end, but what we're trying to do with this work, as a part of it, we're also developing case studies. We will have 8 case studies to start, and the case studies are focused, we really tried to select case studies that highlighted at least one of the programmatic areas or the capabilities was from one of the regions across the state, either Eastern, Southern, North Coast, Central Coast, the metro area. And then also we really tried to balance the type of sharing arrangement. So if you go to the next slide, this is a summary of summary of the CJS arrangements, but according with the spectrum, and the spectrum is developed by the Center for Sharing Public Health Services. And so you'll see on the left side, currently in Oregon, there are 48 instances of informal or customary agreements, cross-jurisdictional sharing in our state, and that kind of mostly can be defined as like a handshake agreement. And there's a couple examples there. And then moving to the right, service-related agreements, those are like contracts or MOUs. We have 29 instances of those in Oregon, and some examples include, Malheur County shares an environmental health specialist with Baker County. Grant County similarly contracts out their environmental health specialist with Wheeler and Harney County. And then with Lynn and Benton, there's a formalized health officer sharing in the Central Valley there. And then shared, the one directly to the right, shared function with joint oversight. That is the counties within the arrangement each oversee the staff person. And there's 28 instances of that in Oregon, and you'll see 3 examples there, one being the regional health assessment. All counties pay in equally to support staff for Lynn, Benton, and Lincoln for epidemiology or an assessment capacity. There's a tri-county mental health promotion with Crook, Deschutes, and Jefferson, and then the Healthcare Coalition of Southern Oregon with Jackson, Josephine, and Douglas. And then there is one example of regionalization. Terry is that example. North Central Public Health District is a regionalized health district with Wasco, Gillum, and Sherman counties. So the idea is that we'll have more of these examples over time, and this will act as a resource to our local health departments as they engage more in different business models and service delivery models.
Does the report have a list of all of them, or just the?
Not a list of all of them, no. But the examples, the maps are kind of that high-level summary. And then there will be 8 case studies further outlining the examples, and it will kind of provide the historical context for it. We really wanted to have kind of a lessons learned piece in that case study, and to hopefully provide insight and value for someone that might be wanting to engage in a similar sharing arrangement. And those are in the process of being completed. So we'll have those soon and be able to share those. The next slide is just fun data from the meetings. At each meeting, for those that attended, you might have remembered that each person was asked how to identify how they personally interact with the public health system. And I included this because I thought it was interesting because it actually aligned with some of the information that we got from the polling data. You'll see that most people say I either take my kids or have gotten my flu shot or immunizations for public health, or I ate at a restaurant, I didn't puke. Clean water and sanitation, and so you kind of can see that. Programs for underserved populations is lower on the list. Emergency preparedness and response is lower on the list. Sexual and reproductive and family health is lower on the list. Car seat belts, was an interesting one. Tobacco regulations. So that's just some fun data, and we'll move into the other thing that I wanted to do that I apologize for not having a slide in here, and so I'll make sure that you're pointed to it. But from this report and from all of this data, we have developed recommendations, and I will. It's on page 13 of the statewide report, but really to review. The recommendations that came out of this data is that we focus as a public health system on change management and really preparing individuals, teams, and organizations for making organizational change ushered in by public health modernization, just to make sure that being at such a large transition that it is as efficient and as smooth as possible. With any change, there are bumps in the road, but being that this was such a large challenge for folks that we felt like we wouldn't be honoring what we learned from these meetings without specifically calling out change management. Number 2, workforce capacity. So really understanding the implications, understanding the workforce implications of public health modernization. Local public health agencies shared concerns around the capacity to hire qualified individuals. That was really clear at the meeting. And so as we are adding new elements to the role of public health, I think we really need to be thoughtful about the availability of the workforce to do that work, or how we make sure there is an available workforce to do that work, or that the work itself is attractive to a new workforce, whether that's with salary or other benefits, I guess, but really making sure that there is a workforce to do this work successfully. The other thing that is very clearly a theme is the role of public health. Where do we fit with a lot of this transformation? Communicating the value of governmental public health services, and especially in a changing environment, the role of public health as we move forward into a future system. Excuse me. And then lastly, the cross-jurisdictional and cross-sectoral sharing, and that most local health agencies have been effective in developing cross-sector and cross-jurisdictional sharing relationships, evident by the maps and the data that we have from these meetings, but really ensuring that we support our local health departments to continue to facilitate these different delivery models and engaging in new partnerships, and really making it a system-wide effort. Because we want, again, to make sure that we are being true to what our local health departments are saying is probably, I know we have $5 million to support communicable disease, and we're going to be doing an RFP to support regional models, but that assessment epidemiology, leadership and organizational competencies with emphasis on training, communications, prevention, and health promotion were really areas that came out of these meetings as local health departments saying that these are things that we can share very easily. So that is one of the recommendations as well. And that is, again, in the report, and so I'll make sure that you all receive that. Moving on to the polling data, and how much time do I have left? Sorry, I wasn't keeping track. I want to make sure I'm not going over.
We can do it fairly quickly.
Okay, so, excuse me. So again, we worked with McCabe Message Partners, which is based out of Washington, D.C., and the Public Health National Center for Innovation. This was funded by Barbara Wood Johnson. But in all 3 states, Ohio, Washington, and Oregon, they did a public opinion poll. And in Oregon, they polled 500 registered voters in the beginning of May, if you go to the next slide. And this first slide is just kind of an overview, but the poll was really designed to explore perceptions of the public perception of public health departments, how confident voters are in the effectiveness of public health departments, and the perceived value of different public health services provided by health departments. Next slide. This just really quickly, I won't spend a lot of time here, is the demographic data of the voters polled. So you'll see it was pretty split male to female. You have also fairly split between 18 to 44 and 45 plus. Most people were white, total non-white 12%. So that's just the overview. I'm sorry, that's the registered voter statistics. On the left, the survey pretty closely matches our voter statistics. Next slide. So one of the questions they asked is of all the organizations, they listed out organizations and they asked people essentially to prioritize those organizations in creating a healthy community. And although, so you'll see on the right the mean, so it was out of 1 to 10, they had people rank. And so all of these on here were above a 7 essentially, but of the ones that were above a 7, public health departments were in the bottom, or the second tier. So people thought schools, fire departments, hospitals, and police departments were more important in creating a healthier community than libraries, public health departments, and parks. Next slide. And this was if a friend or neighbor asked you to explain what your local public health department does. They asked what you might tell them, and these were the responses. And it was actually interesting looking at this. I didn't include the other one in here because it kind of felt redundant, but the other one was like, could you explain what your local public health department does? And one of the first things on there was actually immunizations, and I think, I'm gonna look at Sarah because she also knows the data, but it was WIC too, like services for women and infant and children. But when they were asked to tell a friend, they said public health departments collect data about diseases and outbreaks. They provide immunizations, inform and educate the community about health issues, provide medical health care for those in the community who are low income. And so these are, I think they're in order of kind of their most common occurrence. And so it's just interesting to look at that, and then also what people at the meetings said. How they interacted with the public health system. Next slide, please. And so one of the questions in the poll that they were asked as well was if they were, how good of a job are their local health departments doing? Most people said, I don't know enough about my public health department to say whether they're doing their job well or not, which I think is an important point of data, is that we need more people to know about what public health departments do in order for them to say we're doing our job well. And especially when we are at a point in transitioning our public health system that requires a greater investment from our state elected officials. We need the public to be saying public health is doing a good job and they need more money. About 34% said they're doing well, 15% very well, and then a small portion said they're not doing well at all. So for the people that do know about public health, they mostly think we're doing well, very small say not well. But I think the important key is that I don't know anything about my health department to say either way. And if you go to the next slide, the most important services. Go ahead.
What is the top subgroups table mean?
Oh, so that's just how they broke out the voters. They also had them. I can send you actually all the data, and because I don't have it in front of you, I can't speak. But they broke out the voter population. People identified as women, people identified as Republican or Democrat or independents, people that identified that they were in college. This was how they essentially voted. So, Democratic men, 40% of them said the health departments are doing, of that subsection of the people saying the health departments are doing well, 40% were Democratic men. 40% of Democratic men said that health departments were doing well. And
Okay.
I'm sorry, I'm feeling on the spot. I probably should have had notes in case you had questions, but I can get that data.
No, I just wanted to know how to
Yeah.
read the tape.
Yeah.
The way you just explained it. That's
Yeah.
good. Okay, thanks.
Sorry.
And HH must be household.
Yes.
People working in healthcare know more
Yes.
about healthcare.
Yep.
or public
Exactly. So when asked, there was a list of services that public health departments provide, and when asked to rank those, this is how the ranking kind of shook out. 50% said the most important were women, supporting women's and children's health, such as prenatal care and appropriate nutritional assistance. The next was stopping the spread of communicable disease. The other was bringing together partners in government like police and fires. This is kind of a preparedness question around public health emergencies. And so those were the top three of what people viewed as the most important in public health. And this we'll talk a little bit more about this in a couple slides. And then if you go to the next slide, this one I included because I think some of this data seems like it's in conflict with each other, but at least when talking to elected officials, either local or state, 2/3 of the voters polled believe that ensuring that every community and organ receives all of the public health service listed should be a high priority for our state's government. And so I felt like that was important to include in here because that's a good proportion of people polled of a representative sample, at least of voters. And so I think that that's something that we need to be saying. If you go to the next slide, thank you. So really, they put together these great slides at the bottom line. So of the 9 health department services that we tested, the 3 that I just mentioned, essentially WIC services and prenatal, nurse home visiting, I guess you could probably include in there, helping to stop the spread of communicable disease and bringing others together in government to address public health emergencies. As we've been talking about how do we use this data to support our communications effort, one of the things that our partners at McCabe Message Partners told us is that we have a movable center, and our movable center, if we really want to communicate to that movable center and to gain more supporters, then we need to be talking more about these 3 things. And then the other thing on here, the least important service, was working with partners to help create strong local policies that support health, such as smoke-free workplace laws. That did not appeal to our movable center. And the way they said it, actually we were on a phone call with them the other day, and the way they said it was, you are not going to lose supporters by talking about policies like smoke-free workplace laws, but you're just not going to gain supporters by promoting that. And so I think the message there is that we just have to be really careful about how the way we message if we want to gain more supporters with our communications around what public health is, why we need people to support it. And so not to say that we shouldn't say those things, because I think a lot of people in this room would say, smoke-free workplace laws is a really big public health accomplishment. Like, we've saved a lot of lives. We've really reduced a lot of our chronic disease rates by doing that. But for some people, that just doesn't, it's not convincing as a way to get public health support, I guess. So those are just, I think, some of the important things to think about. And working with Sarah and some of our other local health officials on communications around public health and public health modernization. And these are, and we're really trying to look at this data and think about carefully about how we're messaging things, and while also trying to meet the needs of our public health officials. And then the next slide are just kind of a reiteration of some of the earlier points I made. And then the last piece, that last bullet there, the other thing about the voters polled is that they were pretty divided. And so when asked to choose, voters were divided about whether it was more important for the local public health department to provide direct services to children and families, or to provide or to improve the health and safety and track and prevent diseases in Oregon. And the interesting thing about that was that more women, I think it was probably a way of the question being worded, women were more likely to say it's, if I had to choose, I want my public health department to provide services to children and families, and men were more likely to choose, I want the public health department to track and prevent disease to improve health for everyone. So it's very interesting, and we are, taking the data to heart. We're really trying to think about how we're crafting our messages moving forward. We're working closely with our partners at the Public Health Division. We have a small group of local health departments working with us as well. And so I just wanted to share with you because it's very interesting. And I'm happy to share more if you are interested in seeing more of the data. But if you go to the last slide, I'll wrap it up. Next steps, I already mentioned one, we're working on communications in preparation for future legislative sessions and just general communications. But we are working with the READ group and local public health administrators to develop a concept and a framework for a roadmap that will help facilitate the implementation of public health modernization. That is in draft form right now, and they'll be convening a user panel soon to help finalize that and build that out. We are working very hard to debut that in September. And we are also working with the READ group and our local public health administrators to develop a TA plan, a technical assistance plan, to support local health departments. This was a part of our grant proposal, is that we would do this. And so most immediately, to the end of the grant, but I think also thoughtfully about how we do TA to sustain this work and to continue the support of our local health departments. Are there any questions? Sorry, I had to run through that.
That was a lot.
Yes.
Questions from board members? Good.
Okay.
Thanks. I'm still, okay, say we've been looking forward to this, so I'm still digesting like the polling results. Are the polling results in the report that you mentioned, or is that a separate document?
It's separate, and we've received them as a PowerPoint deck.
Oh, so is there if there's more details about that, I think board members might be interested in having the link to that.
Yeah. We don't have it published anywhere. We've just been using it as an internal document, but I'm happy to have that shared. I'll make sure that Morgan gets that out to Sarah and stuff.
Yeah, we've got it.
Oh, great, Sarah has it too. Thanks.
Okay, yeah, so I think board members would appreciate the full detail there. And then also, the roadmap, as soon as that's available, please share that with the board.
Yes, yeah, absolutely.
Okay, Muriel, Alejandra, any questions?
No, I'm good. I knew a lot of this, so
Okay.
thanks, Kathleen. That was a good kind of review of all that.
Sure.
Yeah, I'm just fascinated with the poll results. I want to see more of that. Good news. Thank you for the presentation.
Thank you.
Oh, sure.
This is Tricia. I do have one really quick question. So back on the slide about if a friend or neighbor asks you to explain what your local public health department does, and it lists out the qualitative answers, was there a percentage of people who said, I just don't know? And what was that, if so?
That is a good question, and off the top of my head, I don't know if I have an answer for you, but I can go back and look to see. I don't think with this one, I'm gonna look at Sarah again, if we actually have like quantitative data attached to this information, or if it was just kind of like here's the list of what people said. But I will look back at the data that I have, and I'll let you know.
Great, thank you.
Yeah, thank you all.
Let's see, so we've had another board member join us. Sophia, thank you. Do we have a quorum? I'm sorry, I'm asking Sarah that question.
I have 7 out of 14 voting members are here. so that should be a quorum.
Is it half plus
I
one?
think it's typically half plus one.
Is it half plus one? Then you're short.
All right, well, I was hoping to be able to approve the minutes, but not quite. Okay, so, anyway, thank you.
I can clone myself. I can pretend I'm voting.
Okay, well, we'll come back to that. All right, so our next item on the agenda is to hear about our periodic report about items from the State Health Improvement Plan, and today it'll be suicide prevention and oral health. So what?
Lisa starts.
Yeah, we should, okay.
School time, that's 8 to 10.
Good afternoon,
Now I'm on. Hi.
Hey everyone, my name is Lisa Miette and I'm the manager for the Injury and Violence Prevention Program in the Public Health Department. Suicide prevention is one of the top 4 injury problems in the state. Second leading cause of death for people under the age of 45. And next slide, if you would. So my opening remarks, I wanted to just draw a picture for you of what puts a person at risk for suicide. Thomas Joyner is a researcher and psychologist who's done an incredible amount of work defining just what suicide is. And he recently did a presentation out in Washington County. Really lucky to have him in the area. And he talks about 3 things that have to be happening in a person's life to make them at risk for suicide. One is a sense of thwarted belongingness. Okay? No group to belong to, no family, feeling isolated. Another is perceived burdensomeness. And then the third is a capacity, and this is a learned capacity for self-harm. And when I talk about that capacity, I want everybody to understand that the capacity for self-harm accrues with repeated and escalating experience that involves pain and provocation, past suicidal behavior, repeated witnessing of pain, violence, or injury. So think about EMS personnel, people living in violent neighborhoods or violent households, repeated injuries in people's life, repeated exposure to pain and provocation. So there are people who are at much higher risk than others. And some of Dr. Joyner's theory, I think, is really grounded in this idea that there are those who have thoughts about suicide. So think about a big circle of people that have thoughts about suicide. Most of them will never die by suicide. And then another circle of people who are capable of suicide. But very few of those people have actual thoughts of suicide. But there's a little bit of overlap where you have a desire and thoughts about suicide and capability. And those are the people who die by suicide. So now that I've talked about that, let's go on to the next slide. Thanks. So we have increasing rates of suicide almost every single year and have for the past 30 years. This is a problem that's not going away and is only increasing. Our suicide attempts among 8th graders are also increasing according to the Oregon Healthy Teens Survey. And our emergency department visits for suicide attempts are also increasing. So pretty much in every measure that we have, suicidal behavior is increasing. Next slide. So we do have some successes though. We're talking about CCOs have met their benchmarks for depression screening and follow-up after a hospitalization. This is really good work and I think is one of the first steps in creating a systematic approach to addressing suicidality. We have an Oregon bill that passed related to suicide training for health professionals. It's voluntary. This bill was fashioned after a bill that was passed in Washington State a few years ago. And their first bill was a voluntary training bill. And then their legislature came back a couple of years later and made training for certain professionals mandatory. We've established in the State Health Division a web-based queryable data system for suicide attempt data and suicide death data, hospitalization data, and we're going to put ED and EMS data on it too. And we're expanding an initiative, which is a new initiative that we kicked off last September called Zero Suicide, and I'm going to talk more about that later in this presentation. Next slide. So this is a picture of what our ArcGIS storyboard pages look like on suicide. So this storyboard can be loaded up with background data, and it can be drilled down all the way to the county level, and we can put hospitalizations and deaths and any kind of data you want in there, resources. And then the left-hand side of the screen, we can load up stories about suicide and what's happening around suicidality in our state. Can also, as you see, regionally show rates in other states and across the nation. And all these maps, when we put them up, are heat maps. So the darker the color, the higher the rate, the lesser lighter the color, the lower the rate. Next slide. We also have what we're calling a data dashboard. It's not really a dashboard, but it's a queryable data system that's up on the web. And you can see there are several tabs up there at the top. There's a suicide tab and there's a firearms tab. Now, excuse me, firearm availability, accessibility, and capacity to use a firearm is a real important piece of lethality if it's coupled with thwarted belongingness and perceived burdensomeness in an individual. So we're loading up data that we can get our hands on that illustrates suicide rates and indicators by year. And on the map you see on this particular picture is a map of Oregon. It's a heat map with counties in the dark blue have higher rates of suicide and counties in the light blue have lower rates. And as you can imagine, suicide is still what you call an epidemiologically a rare event, right? So, but every time there is a suicide, there's an incredible impact from it because there are anywhere from 7 to 10 people who experience what some people call a bereavement that is complicated because of feelings of guilt and shame. So a lot of time when there's a suicide in the family, marriages will break up and those types of things. So you'll also see on this data dashboard, you'll be able to pick indicators and run trend lines in the same way in the opioid dashboard, if you've seen that one. And I think I talked to you about that last time I was here. Next slide, please. A really important event happened in 2012, no, 15. The Joint Commission put out what they call a Sentinel Event Alert. A Sentinel Event Alert on detecting and treating suicidal ideation. And this really brought a focus in the healthcare system to this is an important problem. It presents in your EDs and in your hospitals and in your healthcare primary care offices, and there are definite best practices and evidence-based practices that should be put into place, and they should be done systematically. So this was the first real government, federal level approach to pursuing a health systems approach to suicide prevention. Next slide. And now what's emerged is actually an international movement called Zero Suicide. And if you are interested in this, you can go online and look up the Zero Suicide Initiative. The web pages on the Zero Suicide Initiative are loaded with materials and toolkits for use by health systems. And the first step in a Zero Suicide Initiative is to begin with engagement of leaderships. What one would do in a health clinic, a behavioral health clinic, a primary care setting, or a hospital is to engage the CEO and so are your quality improvement folks in a discussion about establishing a commitment for zero suicide. After that, you pull together among leadership a learning collaborative about zero suicide and take an organizational self-assessment and look at the gaps and the training needs. And then you'd establish metrics in your organization and implement a project. So the project has 7 facets: lead, train, identify, engage, treat, transition, and improve. And in a cycle. Next slide, please. So we have some challenges in suicide prevention. One of them is access to complete data. We don't have a standardized data set for emergency department data. What we're using is data from syndromic surveillance, which is encounter data based on chief complaint, which is a narrative piece in the data that comes to us. It has to be parsed out by methods that are pretty labor intensive, and they're not standardized. So the data that we showed you, about 16,000 suicide attempts treated in emergency departments, is based on taking over several 100,000 pieces of encounter data and sifting through them to look for words that relate to self-harm, suicide attempt. And then cleaning that data, and then analyzing those data, and then making reports available to people. So I just got an email today from someone down in Salem looking for real-time data on suicide attempts. And after I got finished laughing, I wrote an email back to her and I said, so we have something called syndromic surveillance, and we pull the data once a year, and we take staff time about a month of working with those data to come up with the whole numbers. So there was a bill in the legislature this session, Katrina, you might remember the number, I don't off the top of my head, that would have established an emergency department data set that's standardized like our hospitalization data index, but it failed. So, but you know, it was the first time it was introduced, and many bills after 2 or 3 times through will end up passing. So I have high hopes that before Katrina and I retire, there'll be an emergency department data set. I've been working, pushing for it for 15 years now, so it's going to happen, I know. Another issue is ensuring community implementation of a service and programs to promote safe and nurturing environments. Safe and nurturing environments is a concept that Tony Bigland down at Oregon Research Institute and Dennis Embry down in Phoenix, who are both researchers on prevention, coined and have written papers about defining exactly what a public health movement on safe and nurturing environments would look like. And we really haven't come to terms yet with what are our data sources that we can collect that'll help us understand when a community has a level of safety and nurturance that allows people to grow up to adulthood and be healthy, happy, functioning people who contribute to their communities. And so instead of self-destructive or ending up in jail or being injured or dying from injuries and violence. So this is an area of endeavor that we're continuing to work on. It's a concept that we're continuing to work on within the health division with researchers who are interested in this. And disparities in suicide persist, particularly among veterans. Next slide. Okay, so this is a slide that we developed. Oh, it's old data too. Sorry about that. That showed the difference between suicide among veterans and non-veterans, and these are veteran and non-veteran males. And as you can see in that 18 to 24 age group, it's an astronomically high rate of suicide among men that age in Oregon. And then another statistically significant difference is among men 35 to 44 and 45 to 54. And then if you look at the trend lines on the right, veterans versus the general population, you see we are continuing and always have had since 2003 much higher rates among veterans. And when I talked about perceived burdensomeness, thwarted belongingness, and accrued potential for self-harm, veterans have all three of those in spades after they come back from a deployment. Next slide. Yeah.
Lisa, just a quick question. Is this difference between veterans and the general population true across the country, or is it particularly marked sort of here in Oregon or the Northwest?
It's true across the country.
Yeah, I was just wondering, you know, again, if there were some states or areas of the country that, how to put this, I was going to say might be a little more pro-militaristic or whatever, you know, supportive, you know, have military bases in their state, which we don't in Oregon, whether part of it was the acceptance coming back and whether this was kind of, I could see that it was higher, I just didn't know if the disparity was quite as great in other states.
Yeah, actually in Oregon, the challenge, you know, with Oregon being called Fort Oregon, there is no military base to come back to get discharged out of. People will come back to Fort Lewis typically and say, I want to go home, I don't want to stay for the post-vention that occurs after deployment. And they'll hightail it home to Oregon, to a small town where there's none of their comrades in arms are there, and suddenly they're alone in a community that has no understanding of what it was like to be standing in Baghdad or in any other city in the Middle East or Central Asia. So it's a really tough problem. And one of the things the Oregon Military Department did early on in the Iraqi War was establish a reorientation team. It was a really nice piece of work that they did because they made sure that everybody coming back to Oregon had connections with the orientation team. And they were called to come back to Congress and talk about their work because other states also adopted the model. So, but this group will continue to be experiencing the highest rates of suicide. It's the death of despair. Next slide. So if you look at health disparities by race and ethnicity, what you'll see is non-Hispanic white males, particularly non-Hispanic white males over the age of 65, have the highest rates. You also see, something happened when that slide got,
No, what?
there's something wrong with that
The
slide.
left is male and female. This is right.
Okay, non-Hispanic whites and non-Hispanic Native Americans have the highest rates by race, and so when you think about Native American intergenerational trauma, isolation that can happen from reservations. Isolation can happen if you're enrolled and live in the metro area, where our vast numbers of Native Americans live in Oregon. Not necessarily connected to culture. So you've got thwarted belongingness, and if you add capacity for self-harm, you have higher rates. And when you look at white males in particular who have left the workforce and feel that burdensomeness, particularly when they have health conditions, in our violent death reporting system, we collect all the data in the state on every violent death. And one of the things we look at with suicide is everything from health conditions to what's going on with employment and relationships. And we see with that aging group, lots of health conditions, lots of isolation, living alone, divorces, being widowed, and burdensomeness is huge in the aging population. Next slide. So one of the things that we wanted to ask is, we're really going to be working with behavioral health programs, hospitals and health systems to introduce this idea of zero suicide. We have about, I'm going to look over at Megan right now. Megan, how many health systems or behavioral health programs are actually committed to zero suicide at this point?
I'd say we're pretty close to 10.
Okay.
Yeah.
So we're working on 10, we're working expanding that regionally, and we're going to start snowballing those efforts by putting together learning collaboratives and having people from the Suicide Prevention Resource Center come out here and do a learning academy on zero suicide. So it's one of the things that we're going to be talking about a lot over the next 2 years and building. Anyway, thank you.
We may have a couple questions. Anybody? Yeah, you wouldn't mind that.
So I, just in general, have had questions around the state health improvement plan and the work around health equity interventions, just recognizing that most of the health equity interventions in the plan don't focus on race ethnicity. So with the suicide, there's the focus on the veterans population, but we also know that there's an overrepresentation of communities of color in the armed forces. And so my question is, do you know anything about veteran suicide by race ethnicity? Is that information that could be collected, could be shared? And are you doing any research on culturally specific interventions related to suicide risk identification or suicide prevention?
Great questions. There are data that are available around race and ethnicity among veterans, and to get at them, we'd have to go to the Oregon military and get some data sharing with them to pull it out. But yeah, I think we could do some of that research. That's possible. We also, I'd have to talk to the VA about interventions in the VA, because they have the best funded health system interventions. And I know that there's been a great deal of work addressing issues with Native American communities, but I'm not sure about any other ethnic or racial minority groups.
So just a couple others. One that kind of strikes me is whether or not there's any research around protective factors, because when you think about belongingness, right, the experience of being a minority, particularly in the state of Oregon, is one of being othered and marginalized. And so just curious about why that doesn't hold up when you look at communities of color and suicide in Oregon. So that's one. And then the other is just a question around suicide by cop, right, in the Black community. And so if there's any information that you have about that as well. So I guess not to say that the questions need to be answered here and right now, but when we think about how we're going to build out those health equity interventions, I think there's a lot of opportunity to just dive in a little bit deeper when we talk about health equity related to this issue area. So.
Yeah.
I hear you, I agree, and got those questions in my head. I'll be walking out with them. Yeah.
I had one question and then one suggestion too. Have you or are you thinking about linking, or is there a way to link the suicide data to addictions data?
Funny you should ask that. I just heard from John McElveen a few minutes ago up on the 7th floor. I guess 42 CFR Part 2 has been modified, and at least the guidance around interpretation has been modified that will allow us, if we can get within our agency some agreement to move forward, to connect behavioral health data with death data and hospitalization data. It appears, at least according to John, that on the federal level, they're really loosening up their guidance. It used to be, in 42 CFR 2 was put in place back in, I think it was 1973. What was happening at that point in time is we were at the height of a heroin outbreak. And cops were sitting outside of treatment programs waiting for people to come out so they could arrest them. And so 42 CFR 2, and a lot of other things were going on. It was bad. And 42 CFR 2 was put into place to protect people who were seeking treatment. And over, the decades, what's happened is there's just been this huge wall between those data and data for primary care and data for, and it's interfered with the continuity of care across healthcare systems too. So I think recognition in the opioid epidemic and in our suicide epidemic in the US, we're starting to understand that just can't be so anymore.
Yeah, it's just an opportunity to link initiatives and large state level work that is going on. And then just a comment is, I think the Zero Suicide Initiative is really cool, and I would also encourage us to, as we look at that more as a state or public health or health systems, whatever, to look upstream and link it to things like ACEs, adverse childhood experiences, and resilience, to Tricia's point of what are the protective things, and because that even though that's great and it's prevention, it's still relatively downstream prevention, and so kind of going upstream too. So yeah, that's it.
Just for FAB members that may not be aware, as a local public health department, the responsibility around suicide prevention sits with my behavioral health partner. And so
Do the prevention specialists?
no, just statutorily, it's their responsibility to do suicide prevention, not local public health. And there is a requirement that I can't remember if it's a death of a student, a suicidal student, they are required to pull a group together. And we sadly recently had one in our community. And our local mental health authority pulled together a large group that included public health. But the level of involvement across the state, I'm sure, varies widely depending on how closely linked local public health and local behavioral health authorities are. And I think we could get more bang for our buck if local public health was more tightly woven to this, because it is a population health issue.
If I can respond to that, the activity that you're talking about was put into place by the legislature last session, and it requires postvention. And if you can imagine, our behavioral health programs were not doing outreach to people who showed up in emergency departments with a suicide attempt. And many times we tried to do outreach and fund these projects to do ongoing outreach after a discharge or after an emergency department attempt, and the local behavioral health programs didn't want to do that because it was going to require them possibly to take those people into care. So it was an issue of money. So as the transition to the CCOs happened, there was more openness to working with people postvention, and really postvention, as you said, is downstream, and our work in public health is to work in primary prevention upstream. So we are their partners, and they're not the only agencies and communities that need to be engaged in suicide prevention. In fact, we have to get to a point where every agency and organization makes suicide and zero suicide a commitment.
Yeah, so again, my question was about what do we know? So I was struck by what you said about the joint commission recommendations. Do we know what proportion of people who successfully commit suicide, actually have an interaction with a medical or behavioral health provider, within the weeks or months before?
It's about 30 to 40%.
So that means, all more than half do not. Wow. Okay.
And this really varies according to gender. A lot more women are in treatment and care for behavioral health problems, and a lot more women will seek primary care for problems, and they'll experience their psychic and emotional pain physically, and they'll go to, and men do that too, but men won't recognize and acknowledge psychic pain like women will. So a lot of that's socialized behavior. One would hope that that's changing.
So even if you got every healthcare provider in the state on board doing this actively, there'd still be a large proportion of, suicide victims who aren't being used to do that. That's
So,
fine.
but I think part of it too is to, if you will, I hate to, I was going to say normalize or mainstream, so that if people are going into a primary care provider to get their blood pressure checked or whatever, that some of this is done as part of it, because we do know that particularly men won't necessarily say, I'm going to see a counselor, I have a mental health issue, but that doesn't mean that they don't have some contact with the healthcare system. So again, it's still not easy if people are denying, but if it's manifesting itself in symptoms. So again, thinking about it more broadly, not we need more mental health providers, which may be true, but identifying that there's potentially a broader range that can help to do some screening and provide services.
Oh, I'm sorry, so was the 30-40%, did that include primary care plus behavioral health, or was that just behavioral health?
Actually, it's primary care.
Okay, yeah,
I
so,
misunderstood that. I thought it was.
yeah, I'm sorry, I was thinking of it more broadly, Katrina, but thanks for pointing that out.
I have one more quick question. So on the dashboard, is the data of the county heat map, is that the county of residence or the county of suicide occurrence?
Residents. So if a person is like life flighted to Portland after they shoot themselves, right? The death's going to show up in the records of the residents, not where they died. Yeah. Thank you all.
Good afternoon, everybody. I'm Kate Wilcox. I'm the Maternal and Child Health Section Manager here at Public Health, and the Oral Health Program for Public Health sits in our section. However, it is a great and mighty initiative across OHA, which covers not just the maternal and child health populations, but the entire lifespan. We have 6 staff in public health. But we also have one person over in the health systems division who works on the Medicaid side of it, and 2 to 3, depending on availability, over in the health policy and analytics side of OHA. And then we are all under the leadership of Dr. Bruce Austin, who's here as our state dental director. And sitting next to him is Amy Umflett, our oral health team lead for the efforts that are happening here in the public health division. And so when we look at the work of the SHIP, we're really looking at a lot of what happens within public health, but it's very much connected across OHA and across the state. We'll be touching on our OHA strategic plan, the OHA integration plan, clearly where we are with the SHIP goals, how our Title V program fits in, as well as our school-based programs, the dental pilot program, trying to look at new ways of having different workforce within the oral health world, and then our workforce development grant. So we're going to sort of tri-team this rather than tag team. There's 3 of us. So I'll turn it over to you.
So we have seen improvements in 2 of our priority targets, 8th graders who have ever had 1 or more cavities, and the prevalence of older adults who have lost all their natural teeth. We're hoping to see continued decreases in the adolescent cavity rates due to seeing an increase in school dental sealant programs that are operating in middle schools. And we saw some improvement in the older adult measurement, really without any effort from the oral health unit. Unfortunately, we've really never had the resources or capacity to focus on adults in the senior population, where most of our efforts have been focused around pregnant women and children. Next slide, please. So we've had some successes. I think our largest one is around expanding school oral health services statewide. Since 2015-16 school year, we've really seen a significant increase in the number of school dental sealant programs operating in Oregon. And this is due in large part to the CCO financial incentive metric around dental sealants for children ages 6 to 14. We have seen more programs have capacity to serve middle schools because the saturation is at high levels for serving eligible elementary schools. In 15-16 school year, around 88% of the eligible elementary schools were already being served. And eligible means that students are qualified for 40%, at least 40% of the students are eligible for the federal free and reduced lunch program. Also with school dental sealant programs, we've seen an improvement at the Oregon Health Authority on being able to collect data. Senate Bill 660 passed in 2015, which required mandatory certification for local school dental sealant programs. So we're really able to coordinate efforts statewide better, and we're able to collect aggregate level data from that area. We're slowly seeing an increase in school-based health centers offering dental services on site, but we really do have a long way to go before all 77 school-based health centers integrate oral health. So that's one of our priority areas over the next year. And another area of success is having oral health as a priority area for local health departments and tribes to work on for their Title V funding. For the current grant year that started on July 1st, around $200,000 is being spent at the state and local level working on oral health activities. And I'll turn it over to Kate now.
So this is a map of the different counties, and at the bottom are little icons for the 9 priorities that our Title V block grant supports, and oral health is one of them. So currently there are 7 local health departments that are chose oral health as one of their priorities, and they're in the gray. So that's Klamath, Jackson, Douglas, Tillamook, Crook, Marion, and Washington. And then 2 tribes, Cocoa and Cow Creek, have selected that. And those, we support 5 of the 9 federally recognized tribes with Title V dollars. And these 2 actually have been the first, they've been with us the longest and have always focused on oral health as their priority. So this is probably the only source of funding that we have that specifically goes to pregnant women and young children. And so when we're looking at the accountability metric that was chosen, dental visits for children 0 to 5, we're going to be asking you some questions on giving us a little bit more information around the thinking behind that and ideas of where we could take that, because they're just really, we haven't been successful yet in finding some more robust resources around that. But the strategies that these programs have chosen, they're given a menu of evidence-based strategies they can choose from. So they're providing oral health services, mostly education and referral through home visiting, educating pregnant women, parents, and children about the importance of oral health and visiting the dentist. And then, of course, promoting community water fluoridation, which is something that we'll talk a little bit more about next. Next slide. It's on to Bruce.
The slide did change. Thanks for having us.
Your microphone.
There, now I'm on. So again, thanks for having us. And Amy talked about some of our successes and also the lack of success in the area of older adults, or excuse me, the increase in the adult measure, even though we didn't specifically devote resources to that.
It keeps trying.
Flipping off here. Okay, there. But I think our successes are pretty great considering some of our challenges, and part of that I think is just an increased awareness of the importance of overall health to overall health in the state. And that started with legislation and OHA leadership. My position was created in statute in the 2015 legislative session, so I've been here about 2.5 years. And since then, we've had an increased advocacy from our OHA leadership. We have a very robust oral health team that includes membership and leadership from 4 of our OHA divisions. So we're doing good work. We've added some staff, and we also have a lot more of an OHA strategic plan now for oral health. So we do have some successes. We have our challenges, and one of those challenges is that we ranked 48th among the states in water fluoridation. So I think we're doing pretty well with some of these measures, considering our high potential for caries rates. We're keeping the fire down, even though we don't have enough water, so to speak, or enough fluoridated water maybe. The challenges here, and I'll talk about water fluoridation. The challenges are just kind of our slow progress in integration, and not so much slow rate of integration, but we got a later start than behavioral health and some of the other integrative efforts that have happened. Part of that is just that chronologically our integration was required by contract not until 2014, whereas other groups had contractually integrated before that. And then also the fact that the DCOs, the dental care organizations, were fairly entrenched in their autonomy by then, and they kind of liked their autonomy. So it's been a transition for all of us. Next slide now. Here's some numbers on water fluoridation. Unfortunately, we are losing ground a little bit here. I mentioned that Oregon ranks 48th among the states in percentage of citizens that have access to optimally fluoridated water. Many of the states are above 90% access to fluoridated water systems. Portland's the largest city in the country that's not fluoridated right now. And that's a big reason for these low percentages. But you can see the percentages here have slipped, and it looks like we're going to be in the 21-point-something% range for the latest data that we have. And really that's through the loss of just one fluoridated system. That was Newport in the past year or so. Other systems have had challenges, but we've held those off, and that's where a lot of work is right now, is educating water system operators and being attentive to any rumblings in communities where people may want to consider rolling back fluoridation that's been there for 50 years even. And Newport had been fluoridated for over 50 years by 2 votes of the people, and that was overturned. So that's one of our biggest challenges. The other is, like one of the presenters said, funding. But we're not alone in that area. We were, and a lot of that is a lack of federal benefits for seniors. Oregon is one of the 14 or 15 states that's considered to have pretty substantial adult dental coverage for Medicaid patients, and so we're one of the better states as far as coverage goes. I can't imagine living or working in a state with less coverage than we have. So that's good, but it doesn't include coverage for seniors. We're lucky to get a limited duration position to look specifically at oral health efforts for seniors. And LD here on this slide, it actually has a name. Karen will be here at least through next summer, and we're hoping to have some systems in place so that we can instate those when we do have funding and resources beyond that. So we're certainly keeping seniors in mind with these efforts. Next slide now. So back to water fluoridation. This has been one of my passions since before I started this job, but it really is a big challenge for us. If you know anything about the history of water fluoridation in Oregon, and I'm grateful that our state leadership and the ship itself really sees the importance of water fluoridation as an important public health measure. I've heard people mention that community water fluoridation is a political issue, and they shy away from this because it can be a political issue. And I very strongly believe that the community water fluoridation is an important public health measure that sometimes becomes political, but because it sometimes becomes political, that's no reason to shy away from it as a public health issue. It's been completely proven to be absolutely safe at optimal concentration. absolutely effective, and it's very cost effective. And most of all, I think it's equitable. It reaches all members of the population regardless of age, education, income, ability to drive to a dental office, to find a dental office that accepts their coverage or that they can afford, and regardless of education of parents or the knowledge of the importance of getting to a dentist, it's equitable across the population for a very affordable rate. The other point here is the pilot projects that Kate mentioned. These were established by statute a few sessions ago. The dental pilot project bill was to allow the expansion of novel projects to look at alternative workforce issues in dentistry that we weren't able to do by statute before. So we currently have 2 pilot projects up and running. One is allowing dental hygienists, expanded practice dental hygienists to place very conservative temporary fillings under the guidance of a dentist using teledentistry. So it's kind of a pilot project looking at a new treatment procedure for dental hygienists and teledentistry, and a bill just this session passed to allow dental uses for teledentistry, which we're excited about. The other project is to allow dental health aid therapists, that's what DHAT stands for, but dental therapists, a workforce model that's been in place in Alaska and Minnesota and now a few other states for over 10 years. So this project looks at using Alaska-trained dental therapists to come back to some tribal locations in Oregon to provide care much like nurse practitioners or physician assistants do in medicine. So that was debated, and it's pretty well accepted over the last few decades. That's one of our bigger current battles in dentistry is mid-level providers and a lot of pushback from established dentistry. So that's looking like a very good project. We just had our first, or the project just had their first dental therapist graduate from the program in Alaska and just moved back to Oregon in the last few weeks, and she'll start this summer. So now back to Amy.
So a lot of our efforts on reducing disparities have been really around school oral health programs. And school dental support programs, just in the way that the model is that it is really reaching children from low-income families who are most likely not likely to get dental care outside of the school environment. So as part of our mandatory certification program, we've implemented 2 health equity requirements for local school sealant programs. The first is that they must target 40% FRL schools before they target those that have higher income schools. So we don't really want them just focusing on feeder schools into their system of care, but really looking at that as an issue. Second, dental sealant services must be offered to all students, regardless of insurance status, race, ethnicity, and socioeconomic status. And the reason behind that requirement is we just don't want them to see, quote, their kids. So in some areas, you have like 9 dental care organizations that have school sealant programs. So if they all come into the school and just see their kids, it's just not, it's not the model for school dental sealant programs. So for the statewide school dental sealant program that we operate here in our unit, we are piloting a 2-page voluntary questionnaire on race, ethnicity, language, and disability. They'll be attached to our parent permission forms for the upcoming school year. And while it's great that we're going to be able to collect this data, I just want to caution that the downside is that we're only serving 20 to 25 schools next year. At the height of our program, we were able to serve 150 schools, but we've transitioned most of our schools to local school dental sealant programs so that they can meet the CCO financial incentive metric. So next slide, please. So a key data collection tool for us we really rely upon to identify disparities is the Oregon Smile and Healthy Growth Survey. It's really one of its kind, describing the extent of oral health problems as well as overweight and obesity among Oregon children in 1st, 2nd, and 3rd grades. We're still in the data collection phase for the 2017 Smile, We were hoping to finish it during the last school year, but we've had significant challenges trying to get schools participating in it. With the success of school dental sealant programs, there's an oral health screening bill for kindergartners. Schools just don't really value, I guess, public health surveillance as much. They would much rather have direct services in our schools. We also designed the survey a little bit differently this time around from the 2012 survey. So we actually need to survey more schools in order to report on 7 regions versus 6 in the 2012 report. Our partners had requested access to more granular data, so in trying to meet that within our current capacity, we were only able to increase the region reporting to 7 versus 6. So we're hoping to finish up data collection by the end of December, and hopefully both reports will be published in mid to late 2018. And now I'll turn it back over to Kate.
So we came up with, next slide please. We came up with a couple questions for you all to ponder, but we also want to have questions from you. So this is the Q&A discussion portion of the presentation. So do you all have any questions so far?
I have a quick question, but if this is a long answer, you can tell me later. What's the difference between the dental therapist and an expanded practice dental hygienist?
Thanks, yeah. An expanded practice dental hygienist is just a dental hygienist that's had a little bit more training, so he or she can work autonomously in certain settings and do a little bit more unsupervised treatment and work in, say, nursing homes or school-based health centers and so forth. So that's a dental hygienist. Dental hygienists can write limited prescriptions, provide anesthesia, or actually Oregon allows more, the biggest scope of practice of any of the states for dental hygienists. So anesthesia and preventive care, education, and cleanings, the things you think of when you think of dental hygienists. Dental therapists it's a 2-year training program for a high school graduate. Usually these young people come from the communities that they'll go back and serve, so they're culturally related to their communities, which is wonderful, and that's been the beauty of the model in some of the states, especially Alaska, where it's happened. And so they're very accepted and known and loved by their communities, speaking the language or dialect even, which is important. So 2-year training program, they can do, of course, preventive education, anesthesia. They can do simple fillings and they can do simple extractions. So that covers a lot of the more urgent needs of community.
So they could do a little more.
Yes,
Okay,
yes.
thanks.
And that's where the pushback from dentistry has come. And in states where this has been allowed for some time, there are studies showing good quality, good safety, and it opens up the access for dentists to do procedures that only dentists can do, and therefore dentists and offices and dental care programs are more likely to accept more underserved or Medicaid patients. So it's worked out being better for all, even though it's been accused of being a 2-tiered system. Those that have good dental coverage and those that don't. And I say a 2-tiered system is a system where you have access to care or no access to care. Yeah, so it's worked beautifully in the states where it's been allowed, so we're hoping for some good data here that impresses legislators. So I will point out the third question here, and not that this is the only issue I think of in dentistry or public health, but this is really one of our state's biggest challenges, especially when even the legislators shy away from it. We had a very straightforward bill, we thought, pertaining to water fluoridation. It was just simply to notify communities and providers if there were any change in the status of water fluoridation in the community. And we had a good committee and good committee chairman wanting to represent this, and they decided to shy away from it because it was a political issue in favor of some of the bigger ticket items this legislative session. That's kind of been the history of fluoridation in Oregon. This was not even to change any fluoridation status, just to, in the spirit of transparency, to provide notification, and so the legislature ducked away from that one. So that's going to be our challenge. And we have an active work group looking at water fluoridation very slowly, methodically, thinking about education and pulling stakeholders together and so forth, but we don't have the answers yet. So of course that's not an easy or short answer for you all, so ponder that.
It's something we'd love for you all to ponder and work with us, and maybe at some point in the future when we have the full water fluoridation communication plan, we could come back and share that with you. And we're working on the short, the medium, and the long-term goals, knowing that we have to build kind of the constituency around this, and we may or may not be successful, but the focus right now is really to stop any, what's that word? The rollbacks, that's it, rollbacks of current systems that are fluoridated. So, the other question that we had, and is this, the first one is an interesting one too, and I don't know if there's any easy answers, partly because we aren't quite sure what's going to happen with the adult benefits quite yet, with the uncertain future of healthcare from the federal level. But certainly, number two, we were happy that oral health made it into the accountability metrics. But we're wondering what some thinking was behind that, and if you had any thoughts that you wanted to share, so we can take that forward as we're working on plans.
Was there any, I mean, I guess I'm turning to our members of the Accountability and Metrics and Accountability Subcommittee that developed those measures in more detail.
And I don't know if Muriel remembers conversation specifically, and I'm looking at Sarah. I think part of it might have been that Ely was a very strong advocate for it being on the table. That there was not another oral health metric anywhere in the discussion, and that there needed to be one.
Yeah, and this is Muriel, I would agree. We had a robust discussion about it.
Led by Eva.
And from my perspective as a primary care physician too, I think it's really important from a systems perspective regarding integration and as you guys already said, and also we know the recommendation that kids should see a dentist within by the first tooth or first year. And what happens almost always in real life is either the primary care people don't know that, but even if we do, and we follow evidence-based medicine and we send them, almost invariably, almost 100% of the time, the patient comes back and says the dentist won't see me. So it's a bilateral conversation. So as you move forward in your work with this, if that's the recommendation, then it has to be throughout everywhere.
Right.
Yeah, thank you.
Well, what's interesting is Amy's been through, 3 of these workforce development grants, and the first one that she developed here was First Tooth, which is exactly what you're talking about. And in the great transition of things, it was supported by federal funds, and then we actually rolled it to ORAC, the Oral Health Coalition, which is great. So they're holding that right now, and it's available for purchase, if you will, to come and do training. So I think that is one of the avenues we were thinking, is if we could find resources and whatnot to be able to roll that out more broadly in communities. They also have Maternity Teeth for 2, which looks at the prenatal portion, so it's even getting more upstream, working with pregnant women, and then being able to also have the education about the importance of that first.
And that too, this is less invariably, but a lot of dentists won't see pregnant women too. And so our dental director at Kerrigan says that's just part of, like, historically their training is they're told don't touch kids and don't touch pregnant women. So it might be something to work with the dental schools on too.
Yeah, thank you. Those are good points, and I'm very aware of that.
Figured.
So is Ely, our dental school representative.
The community water fluoridation, and having lived through a challenge in my community to our community water fluoridation, a very small one, but Dr. Haney lives in the neighboring community that is not fluoridated, and he was right there with his t-shirt and his posters, and he's a great advocate. we face the same conversation around immunizations because there is so much misinformation on the internet. But what we don't hear, the dentist came forward in the community when there was a threat. And I know often the Dalles and Hood River are used as a model because the kids in the Dalles are poorer and have better teeth than the kids in Hood River, which is not fluoridated. But the dentist came forward when there was a challenge, but we don't hear it on a regular basis. We're not hearing dentists and medical providers stand up and say, it's important to fluoridate the water until there's a challenge. And so I don't hear parents being told, oh, if you're mixing formula, you need to make sure that your water's fluoridated. When your kids, don't feed your kid, don't go to bottled water at home. Make sure you're getting kids water out of the water system because it's got fluoride in it. We're not hearing that, and we know that primary care providers have such an impact on families, and I know the time is limited, but these sorts of upstream messages need to come out of that primary care office because that's generally the only place families are touching a healthcare provider. And I just know in my community we're having that conversation around the birth Hep B dose, and nobody wants to take accountability for whose responsibility it is to talk to families about the birth Hep B dose. Nobody wants to take, it's like, well, I'm the mom's doctor, it's not my responsibility. Oh, well, the baby doctor doesn't see him until after the baby comes. And so I think it's that same thing is people, I don't know how it happened in the 10 years, 15 years I've been out of like acute care, but people are siloing themselves more, and it's like this, oh, well, that's the mom and I deal with the baby, or that's the baby and I deal with the mom, and I'm like, when did they get unconnected? So I think we really need to do a lot of work with providers about how the conversations need to go so families get the right information, because they're not hearing it from their primary care provider that fluoride is important.
Yeah, you make really good points, and I'm very glad you know Chuck Haney. You know how passionate he is about this. And one thing we've seen is that patients and populations tend to trust their primary care providers and pediatricians more than they trust the dental profession. So you're right, the message does need to come from there. And part of that is because the people that are against water fluoridation or against vaccines, they think, oh, if this profession is in favor of fluoridation, there must be something in it for them. So you're right, it needs to be a multidisciplinary approach, and we're seeing good benefits with pediatricians carrying the torch. Thanks.
So,
I think we have probably time for one last question.
Comment and a question. One, I just really want to applaud you for the workforce development work that you're doing, which is so, I think, embedded in a health equity framework in the ways that you've mentioned. But I also think the building community trust is huge, that early intervention is huge. I think that might be your strategy if you're going to build that out, for building more local support for community water fluoridation, because those are already trusted messengers, right? So the way you talk about it, to me, it sounds like a community health worker model with an oral health focus. And I think there's huge kind of long-term opportunity there. The question that I had was when you talked about the decrease in the number of schools where you're doing work as public health because of the relationship with the CCOs, and I'm just curious if you could talk a little bit more about whether you feel like that's success, because you talked about it like it was a decrease, but if CCOs are taking it on, it sounds like it may be an increase, so I'd just like to get more context around that.
So our unit, we operate the statewide school-based dental sealant program, but it's operated with general funds. But we've been operating since 2007. We had general funds, and we were able to serve 150 schools. And once the CCO metric came on board, everyone wanted to start operating a school sealant program, and that was one of the reasons why we have the certification program, because not everyone knew how to operate in a school. It's a very different environment from school versus a clinic. So as programs were trained, got more capacity, we started to transition our programs to it. In terms of like disappointment, why it went down to 2025, it's in terms when we're talking about the Real D form. So we have this goal to implement this great tool where we can get some more information around disparities, but now that we're down to 2025 schools, that's really the only data collection that we're going to be able to do, because I can't force local sealant programs to add this 2-page optional questionnaire, and then we don't have a statewide database where we can capture all the data. Right now, we're just able to do aggregate level data from the programs. We are excited that that we've seen, I mean, elementary schools are pretty much going to be served with a 40% FRL level. We're in like 95%, I think, is close in the 2016-17 school year. We have a little bit ways to go in middle schools. I'm a little bit cautious moving forward in case the dental sealant metric changes to a different metric, and we'll kind of see if they continue to take on the amount of schools that they're serving.
Let me follow up a little bit. So it sounds like we're decreasing, the state program is smaller, but that's because we're shifting our role from direct service to assurance. And so actually more schools are being served, almost all of the first, second, third graders, and as Amy said, we're getting more and more of the middle schools. So it is a shift, and then with the extra resource that we have, we'll be able to provide more technical assistance to those local programs to assure that the quality of the program stays at the certification level.
Who's doing the local?
A variety of programs, they get trained by us, and then we certify them, and then we keep track of who's in what school, which has been an interesting process because two programs may want the same school, and the CCO has to get involved in the school, and so, but we're figuring it out. Yeah.
I just have 2 comments around the Real D piece. So one is that a lot of the work that came out of OHA around Real D was looking at school districts who already collect more granular race, ethnicity, language, and disability data than healthcare has. So the schools actually have, a 10-year or so head start on health care, so there might be some learning there rather than feeling like we're losing something. And then the other piece is that the CCOs, if it is a CCOs who are participating in that, are also accountable to the same Real D law as public health is. So.
Right. I think what we're sort of proud of in terms of rolling out Real D within public health, we kind of seized this moment of being able to adjust the forms and working with Marjorie McGee on that. So it's sort of been, the benefit is our program, but it's also the benefit of being the first one to try to get it into our system. So, but you're absolutely right. And with this SMILE survey, actually for the first time, we have a data sharing agreement with the Department of Ed to be able to get the race and ethnicity and language spoken at home data, so we can match that up with those schools. So yeah, so it's really exciting.
Good, thank you. So I'm looking at our agenda. We're running behind. We've got a couple items remaining on our agenda: the guiding principles for public health and healthcare collaboration, and then talking about the guidelines for how the modernization funding will be distributed. I'm going to ask if we could consider deferring the public health healthcare collaboration guidelines discussions. Safina, I know you.
I don't care. I just might not be able. I'm definitely not going to be here next month, and depending on how things go with me, I might not be here in September. So that's
Okay, yeah, well, right. So we're not meeting next month.
Okay.
Our September meeting is
I probably will be here in September, but I'll be
Yes. Do we understand?
But that's totally fine.
No, we don't have a form to adopt.
Yeah. That's my other concern is that we were going to take a vote at the end of the discussion, right? And we don't have a quorum.
I should be.
Okay. And if you're not, would we be able to find some.
We have slides.
Yes.
Yeah, and then we can talk and I could like talk you through what we did.
Yeah, if that's, because we definitely want to get the information. Okay, thank you. Appreciate your flexibility. Okay. Okay, so, yeah, Carol, let's add that to our September agenda. Could we take a break for just a few minutes, just to get up and walk around a bit, and then we'll come back and talk about implementation funding? Yeah, so the subcommittee updates will be really short, and then we'll talk about modernization implementation. So Alejandro, Muriel, we'll be back in 5 or 10 minutes.
lots of support. Her mom and dad were there, and that's essentially all she did for a while was keep them up, and everything was very scheduled. But she successfully read the rest of those curriculums. They're happy 12-year-old girls now, living in New Zealand.
Good friend of mine from college.
That's
had
called
triplets.
prevention.
Yeah. Triplets.
Boy.
Yeah, one of my nurses her triplets just graduated from high school, and she's like, "Whoa, they all 3 graduated." She was so excited.
So welcome back, everyone. We just we're reconvening to talk about our final topic for today. So on our agenda, our guiding principles for public health and healthcare collaboration. We'll return to that at the September meeting. We'll hear from Safina and Kara at that time about some discussions they've had with organizations outside FAB. If any other FAB members have any feedback, they can bring it at that time. But we will vote to adopt those guiding principles. So we'll need to take that up at that time when we have a quorum, actually. So our last item for today is to discuss the public health modernization implementation and concretely the guidelines for how the legislature, the funds allocated by the legislature would be distributed to local health departments. So Kara's going to walk us through that in more detail. I'd just like to set the stage a bit by talking about our incentives and funding subcommittee meeting, which was held on July 11th. The minutes of that meeting are in your packet, and so that's actually what we're looking for on the screen is those minutes. So could we move forward just maybe back one page? Yes, thanks, that's it. So this I'll direct the committee members to look at, let's see, let me find the page number. In your packet, it's page 60. So page 60 is from the minutes, but the important thing on there is the 2 bullet points that says FAB recommendation from May 18th and CLO and JLT recommendation from June 8th. At its May meeting, FAB developed some recommendations for how any funds that were allocated by the legislature for modernization would be distributed to local health departments. And then CLO and its joint leadership team had a subsequent discussion where they commented on some of those recommendations and also made some more detailed recommendations. So those 2 sets of bullet points that start on page 60 and end on page 61 are really the guidelines that Public Health Division has used over the last few weeks in developing its scenarios for the legislature, and now that the legislature's allocated some millions of dollars over the next biennium, actually developing a process for distributing that money to local health departments. So we talked in the incentives and funding subcommittee meeting about how those guidelines would be implemented. Public Health Division has developed what you'll hear is a 2-track system for distributing money to groups of local health departments. So projects will have to include more than one local health department on a sharing basis. We'll focus on communicable disease with a health equity emphasis consistent with the content priority, with the program and capability priorities that we've discussed. But the incentives and funding subcommittee gave its general approval for the 2 tracks of larger and smaller grants, and then asked for some more specificity on some of the scope of work. So I think what you're going to hear today is something that was in general approved by the Incentives and Funding Subcommittee. I know that Chloe has subsequently talked about it. I'm eager to hear any feedback from that discussion. But just before I hand it off to Kara, are there any members of the Incentives and Funding Subcommittee who'd like to add anything else from our discussion last week? Okay, thanks. Kara?
Okay, thanks, Jeff. That sets the stage pretty nicely. So, just briefly again, we have $5 million in general fund investment to work with for the 2017-19 biennium. And we've been talking about what we would do with any potential resources for several months. So I think that we've really come to some consensus between the work of FAB, the work of the Public Health Division and CLO Joint Leadership Team, and the work of CLO. As Jeff mentioned, and here it is in front of you, funding along two tracks. One would really be focused on regional implementation of communicable disease control and health equity strategies. And then a second track that's really focused more on capacity building. So perhaps for jurisdictions that don't have a natural partner that they've been working with to think about regional implementation, a small portion of funding to get them to a place where by the time we're through with the biennium, they would be fully ready to implement similar strategies to track one. So we have had a subsequent conversation after the subcommittee met last week, earlier today with Joint Leadership Team and with CLO. I think that there's still an interest in maintaining track 1 and track 2 based on that conversation, but the track 2, really trying to focus that directionally towards getting ready to deliver on outcomes, I think was the bulk of the conversation. We really don't want to drop the ball on that, even though I think would be a relatively small proportion of the overall investment. We also talked about flexibility within the communicable disease control focus area, and then really needing to align that to local need and changing our business structures. I think other pieces that have come up have really just been some more specific guidance around what the expectations are for regional commitments to this work. So I think that's something that we can fold in. But overall, consensus towards moving forward with this model. Yeah.
So just clarification, because communicable disease control, reducing health disparities, they seem like two slightly different pieces of work. I'm not saying that there aren't certain communicable diseases, but are those kind of different buckets, so that's sort of two focus areas, or is it health disparities in communicable diseases? I mean, I don't quite understand. And at a minimum, there needs to be sort of a comma or something if they're separate thoughts. When I look at track 1 on whatever page this is, 66, I don't quite understand why 3 was just included above, because again, it seems like it's somewhat of a different concept.
Yeah, so that's a good point, Katrina, and that's something that the subcommittee had discussed. So originally there was a specific strategy around communicable disease control and then health equity more broadly that would span across. The subcommittee recommended that with a small investment like this, we really focus the reducing health disparities through communicable disease work. So using data to identify within your jurisdiction what communicable diseases are the largest priority, and then of those where there are disparities, and making sure that we're targeting interventions towards those populations.
So I understand the concept, so it's reducing disparities or addressing the health equity within communicable disease. It strikes me, and I don't know this for sure, but some of the biggest health equity is not related to communicable disease. It's related, I mean, we just talked a minute ago about suicide or about access to healthcare or chronic diseases or all these social determinants, not necessarily who gets meningococcal disease or who comes down with salmonella. I mean, I'm just saying.
Right. So I think that would be part of the strategy development that would be broader based on an assessment for the local area.
Yeah, one thing I was struck by in the presentation we heard from about the AIM meetings was that in terms of, areas of public health activity where cross-jurisdictional sharing was most common, that communicable disease was not, I think it was number 5. So there were, but I don't know, I'm not sure. I think that's just an observation. I think we've spent, so much time over the last few months, identifying communicable disease as a priority that, I still support, moving forward that as our priority here.
Okay.
Sorry, go ahead.
That's okay. So, I think again, what we talked about in terms of minimum qualifications for participating in track 1, and this was changed slightly from the conversation with Chloe this morning, that we would have at least 2 local public health authorities working together and 1 partner organization, and all of these partners would need to have a formal letter of commitment to the work. Is there anything else, comments or thoughts folks had about the implementation track? Okay, so let's move to the next page and talk a little bit more about capacity building. So,
I'm sorry, just sort of waking up here. So I'm wondering, and I'm not disagreeing, I know about the modernization assessment, et cetera. I'm just wondering how much of this is actually driven by the data on the outcomes, like which communicable disease are we talking about specifically? I mean, is it increasing immunization rates? Is it STDs? Is it foodborne? I'm just trying again to understand and make sure that what's being addressed, and I understand this is sort of a different regional partnership idea and how you might approach these, so I get that part. But I'm just thinking we ought to be using data to drive this, and maybe if it's sexually transmitted infections, that certainly is something that we have seen pretty large numbers of. There is regional variation, there is a number of things. So again, I'm sorry if I'm getting pretty granular, but I'm still trying to figure out how this would actually play out.
So there was conversation this morning at CLO about what communicable disease you would be working on, and that would be identified. Colette was in the room, and there originally was some conversation about should we pick what we're going to work on, and everybody writes their proposal toward whatever disease we as Oregon decide we're going to tackle. And that was actually decided against, and Colette was not in favor of that because she felt that it would, that's Colette Young who works, she's the acute and communicable disease program manager. Did I actually get that right? No.
She's now the center administrator.
Okay, all right. So she just felt like that picking one was not necessarily the best way to go, and that we would have a difficulty moving the needle. There is going to be a FAO, which is the Public Health Administrators phone call on Monday, and Colette said she has some ideas based on the data, and she can discuss those now, but she can't discuss them once the RFP goes out. So she's going to be on that phone call to be able to talk to local administrators about some ideas she has from what she's seen in the data, because you guys have better access to what's happening statewide than we do locally, kind of. So.
No, thank you, that's helpful. And I wasn't actually suggesting pick one and stick with it. I was saying that as part of this, it would be good that when people in this proposal are looking at the data to drive what it is they're going to do, and that those proposals might look a little different in different parts of the state. But I just didn't see, I saw broad communicable disease and then health disparities, and I just think it's important that the data on the scope of the problem are included when we are selecting how a region might approach it. So that was my only point. It's not that we have to pick one chlamydia and that's all anybody in the state is working on and that's what our regional approach is. It's just that I don't want
5 million's not enough.
Exactly. I don't want this election to be done in the absence of the data. So sorry, Kara.
No, I just like to really reinforce what Katrina said. There was, based on the subcommittee discussion, also in the subcommittee we had a discussion about should it be one disease or not. And we were also supportive of letting local health departments pick the particular communicable disease that they focus on. But we wanted it to be a data-driven choice, either from assessment epidemiology data that's available from the state or locally. It could also be based on the modernization assessment that was done. So I think, Kara, I'm not sure how clearly it's in here, but I would like to see the requirements for the evaluation of the proposals be very clear that that the data source be described, basically that we use data to justify the choice of that condition in that grant.
Yes.
Does that sound?
That,
Okay.
then
Thanks.
I'm completely happy.
Yeah. Yeah, and just to kind of clarify process a little bit, because this is our new iteration of navigating funding opportunities. Chloe is really dove in and joint leadership team into the details of the scope of work in terms of activities, and FAB really setting the overall framework for how we're moving directionally, what broad principles we want to apply, really thinking about the structure. So we've kind of separated those two pieces out. That's part of what you're not seeing in front of you. So. All right, let's move on to track 2. So again, this is just focusing a small amount of money on areas of the state that might be ready to adopt, but not necessarily in a place with their partners to do this work jointly. So the deliverables here are really more on developing those partnerships and being able to implement by the end of the biennium.
Kara, the only question that came up at CLO was if no one applied for track 2, would those dollars roll into track 1?
Yes. And I think if we go to the next page.
So can I ask about the reverse of that? In the subcommittee, we talked about what if we got a bunch of applications for track 2, could we potentially put a little bit of put some extra money from track 1 into track 2? Did that come up at all in CLO? The subcommittee, so I guess the subcommittee was open to the idea of funding, of not having a hard cap on the track 2 if there were good applications that came in.
There was actually some discussion at CLO about eliminating track 2. And there was discussion that we really felt like that increased the disparities. I'll let Carrie speak to that conversation.
I was just going to say that I think that we've consistently talked about our concern that we need to be focusing on projects that will deliver outcomes that we can go to the legislature and say, these funds were used for specific outcomes. And I think there's concern that maybe track 2 doesn't really get us to the point where we can go and say this investment led to this result. And so I think that's why we focused on whether or not we should include track 2, is just because we're thinking ahead to how we present the outcomes of the work. So I think that, but also to go along with that, we definitely talked about how with track 2 we need to focus on creating it and developing it and in a way that we can demonstrate the outcomes of that process, even if it's not necessarily a specific communicable disease outcome. Does that make sense?
For track 1, we're expecting a focus on both public health, governance systems change outcomes, and communicable disease. And then for track 2, it's really more on the public health systems change, hoping to also tie in those communicable disease outcomes. Okay, so the last piece that the subcommittee looked at was potential ways to look at allocating funding. So if we're looking at a dollar amount of approximately $3.9 million, having jurisdictions that are applying together be broken up into 3 different regional partner sizes with a not to exceed sort of based on size. So, the more partners you get in the pool, the larger you could move up on the scale potentially. And then the regional partnership funding being at a smaller level. Again, Jeff kind of mentioned what could we do to flex money between these two categories based on the types of proposals that are received, knowing that all of the money would go out in some way based on the applications. Are there any comments on this?
Was the did the size bands get discussed at the club meeting? Okay.
There wasn't a lot of conversation.
Okay. Yeah, and the subcommittee discussion also, thought it seemed reasonable.
I have a quick question.
Sure. Yes.
Isn't the minimum qualifications from the implementation one? I guess I don't understand. The implementation one, the minimum qualifications require part. Oh, it's capacity versus implementation. Okay. I was thinking what partnership versus partnership, and I was they're both partners.
Okay, so I'll just walk through then our timeline that we're going to be working with. So again, it was really helpful that we had all the conversations leading up to now when we actually know what kind of an investment we're working with so that we can really hit the ground running this biennium. So we are already well underway to have a funding tool. We need to still work through our internal process, which takes several weeks. But our hope would be to get the funding tool out to local public health authorities in late August to September, have 45 to 60 days open for that, and then select and award by early November with contracts underway no later than January 1st of 2018. Questions or comments?
Good. No, thanks. This timeline is something we'd asked for last month, so thanks. This is what I was hoping for.
Great.
There was a question that came up after Chloe adjourned. So the $500,000 would be funding for the 17-18 months, or the amounts to exceed that grant
Yes.
funding would be for that 17-18 month period.
Yeah.
Okay.
Yeah.
So Kara, you guys will be, so Public Health Division will be moving ahead with finalizing the RFP in collaboration with Flo and issuing it in August and doing the review according to this timeline.
Yeah, we are trying to move as quickly as we can.
Great. But the reason I asked that, the reason I just say that is because this board will not meet again probably before that. Well, yeah, this board will, that RFP will come out before this board meets again. So, as you say, I'm glad we've had a chance to talk about it. I had asked Sarah before the meeting if we can just give a brief email highlight to board members who are not able to be here today to pay particular attention to this part of the discussion, so that if there's any board members who weren't here today who have important questions or comments to make about this process, to please do that as soon as possible so that it can be incorporated.
Great, thanks. And I feel like we kind of, at least from my perspective, we just kind of rolled right from legislative session into starting to work on rulemaking, we'd already been laying the groundwork for all of this, so we haven't had a chance to actually sit back and celebrate the fact that we did have an investment that came out of this session. We had a bill that passed unanimously, so I think we should all be proud of the fact that we really pulled together, and the board has been instrumental in moving the work forward and making our priorities very clear and well articulated, so thank you.
Well, you're welcome. But I think actually I was really struck by all those meetings in Salem where we just had the whole public health system there together. So I'm glad that actually materialized into what we're talking about now. Okay, so any other questions or comments about modernization? All right, thanks. Our last agenda item today would be to request public comment. Do we have anyone in the room who's signed up to make public testimony? No. Okay, so there are no members of the public here at the meeting in person who signed up to make testimony. Are there any members of the public who are on the phone who would like to make a brief testimony to the board today? Okay, I'm hearing no requests for public comment. I think we can close the public testimony portion of the meeting. Okay. I believe that actually concludes our business for today. I can ask for a motion to adjourn, but I don't think we have a quorum. So. I think we can adjourn by consent.